Welcome, everybody. Today, we're presenting our annual Sentinel public training. My name is Judy Morrow. I am an assistant professor in the Department of Population Medicine at Harvard Pilgrim Healthcare Institute and Harvard Medical School. At our department, we house the Sentinel Operations Center, and we're thrilled today to be presenting to you this great program, leveraging the Sentinel system for signal identification among infants following maternal medication use during pregnancy. To kick us off for today, I'd like to introduce Dr. Robert Ball. Dr. Ball is the Deputy Director of the Office of Surveillance and Epidemiology in the Center for Drug Evaluation and Research at the US FDA, which is the programmatic management home of the Sentinel system. Prior to that, he was the Director of the Office of Biostatistics and Epidemiology in the Center for Biologics Evaluation and Research, also at the FDA. So he has a long history of monitoring post-market safety of drugs and biologics. He did his medical training at Georgetown University and completed his MPH and residency in occupational medicine at the Uniformed Services University of the Health Sciences, sometimes people call it USHS. And in my favorite fact about Bob, he is a fellow Navy veteran. He is board certified in occupational medicine and also in clinical informatics, and I'm thrilled to welcome him today. Thank you, Dr. Ball.
Thank you, Judy, for the introduction. And it's my pleasure to welcome everyone to Sentinel's annual training day. And I think it's especially important that we're talking about pregnancy safety. As most of you know, pregnancy safety has a long history of importance at FDA. And as part of that long history, some of you may know that the FDA has made commitments around pregnancy safety under the Prescription Drug User Fee Act, number 7. And to fulfill that commitment, FDA will be holding a public workshop this September with a focus on optimizing post-marketing pregnancy safety studies. So as an additional part of that, we'll be focusing on demonstration projects, evaluating different types of pregnancy safety studies to optimize their performance. And while we won't be talking about today, we wanted to take advantage of this opportunity to overview all of the great work that's been done in Sentinel over many years, and to kind of set a baseline for going into that workshop in the next couple of years of work where we fulfill those commitments. And today's presentation will hear some about Sentinel in general, and in some more general methodology about detecting medication adverse effects in Sentinel, and then taking a deeper dive specifically into surveillance of adverse outcomes following medication use in pregnancy. And we'll also be looking at a case study on first trimester exposure to fluoroquinolones for looking to see how the signal identification methods work in actual practice. So before we get started, additionally, I'd like to thank all the presenters today for sharing their time and expertise, and thank all of you again for joining and listening to this great set of presentations. So I'll hand it back over to Judy to get us rolling. Thanks.
Thank you, Dr. Ball. It's a really important framing for all of our work today to be thinking about how this fits into the bigger picture of pregnancy safety. And so I'm just going to let you know we have a brief introduction for our two speakers. I'll introduce them more at length as we get started. We have two folks who are presenting to you today, Dr. Shruti Admadiam and Dr. Ashley Martinez. Both of these guys are research scientists at the Sentinel Operations Center, again, housed at the Department of Population Medicine at Harvard Pilgrim Healthcare Institute and Harvard Medical School. I'll give them a more lengthy introduction once they start speaking. Our agenda for today, as you already heard, we had some brief opening remarks from Dr. Ball. We're going to then go into an introduction to Sentinel, a session on detecting medication adverse effects. We'll take a brief break, and then we'll go into 2 more sessions, one on looking at infant outcomes following medication exposures, and we'll end with a case study of first trimester fluoroquinolones to illustrate all of the work that we've done today. We're going to then close and send you guys off to lunch and hopefully a great program that you've enjoyed this morning. So we have a couple of housekeeping and logistics items to go through. First, we're going to be doing some polling. So in a few moments, we're going to go to opening a pre-training poll. This helps us to understand our audience and understand what the knowledge level is, so we know that we're targeting the training correctly. We'd really appreciate your participation in it. It is an anonymous poll, and it just really helps us to improve training in future years. So we'd really appreciate when we open the poll if you participate fully. So we also have logistic-wise a question and answer box in the Zoom call. We request that you channel all of your questions into the question and answer box. We will try to answer clarifying questions as soon as we can, and we will hold discussion questions for after the presentations with our presenters. Finally, in terms of presentation availability, this Zoom meeting is available in closed captioning. You can enable closed captioning if you'd like in your meeting invite. And then additionally, this whole webinar today and video will be recorded and will be available on the Sentinel Initiative website. That's www.sentinelinitiative.org after our sessions today. And so now we're going to go to the polling. Our first poll is going to be started now. So everybody should be seeing a poll appear on their personal screens. Again, these responses are all anonymous, and we really appreciate your full participation so we understand a little bit better about our audience and how to cater our future trainings. So if you would please go ahead and start answering the questions in the poll, we would greatly appreciate it. We're going to leave the poll open for a few moments while our responses come in. We'd very much appreciate all of your participation. We're going to hold the poll open probably another 20 to 30 seconds. I'm just seeing those numbers just slow down just slightly. So we really appreciate your answering these questions. Again, it really helps us to target and tailor our future trainings to be most useful to you. Okay, and so we're going to go ahead and close the poll. Thank you so much for your participation this morning. We really appreciate it. And so we will move on to our first speaker. I am delighted to introduce Dr. Ashley Martinez, who is a pharmacoepidemiologist and pharmacist who primarily did her training at the University of Kentucky before being appointed as a research scientist in the Department of Population Medicine at Harvard Pilgrim Healthcare Institute and Harvard Medical School. She is particularly interested in evaluating outcomes associated with the treatment of chronic conditions, especially among older adults. She's going to be talking to us today about the beginnings, the introduction of the Sentinel system, and as our speaker for session 1. Thank you, Dr. Martinez, and take it away.
Thanks, Judy. I am really excited today to talk in our first session, first about a little bit of contextualization with the history and the purpose of Sentinel before we delve into the components of the Sentinel system, its main components being the data that it houses and its analyses. We'll end this first session with a discussion of Sentinel's commitment to public accessibility. The evolution of the Sentinel system has taken place at quite a fast pace, relatively speaking. Less than 2 decades ago, Congress recognized that we didn't have a national system whereby the vast amounts of existing electronic healthcare data could be leveraged to assess the safety of approved medical products. This realization led them to enact the Food and Drug Administration Amendments Act, which required FDA to create such a system in collaboration with public, academic, as well as private entities. And by 2009, less than 2 years after its official mandate was enacted, FDA launched what we now call the Mini Sentinel pilot program. The purpose of Mini Sentinel was essentially to establish the infrastructure that would be needed for the full Sentinel initiative and to validate that what was envisioned could in fact be accomplished. It only took 2 years for Mini Sentinel's distributed database to reach the mandated 100 million lives in which we could assess medical product safety. And not more than a year after that, Mini Sentinel finished its launch of the original analytical tools, thus completing the 2 key pillars of what make the Sentinel system, its data and its analytics. After a few more years of validating the data and tools, Mini Sentinel had shown that it could be successful. It proved its strength and to the point where the full Sentinel system could be launched with great success in 2016 to build upon everything that Mini Sentinel had made possible. And since then, the Sentinel system has continued to grow and enhance. While the Sentinel system's core efforts have focused on medical product safety surveillance, FDA has continued to expand ways that we can use Sentinel data for a wide variety of crucial projects. And in fact, as recently as 2019, even expanded and reorganized into 3 distinct centers, highlighting our 3 core missions. These 3 centers work together to advance regulatory science using real-world data in the Sentinel system, led, as we mentioned earlier, by FDA's Office of Surveillance and Epidemiology and the Center for Drug Evaluation and Research. Each center operates independently and has its own dedicated leadership team and dedicated staff, which carry out projects associated with that center's strategic objectives. The Community Building and Outreach Center focuses on communication and collaboration. The Innovation Center focuses on developing innovative methods to further advance Sentinel. We at the Operations Center use the Sentinel Common Data Model and our suite of analytic tools to answer FDA's questions about the risks and benefits of marketed medical products, in addition to continually enhancing our analytical capabilities. These enhancements are at the core of what has made the Sentinel system so robust as it's moved through its life. FDA consistently commits to maintaining and enhancing the Sentinel system through various mechanisms, including the Prescription Drug User Fee Act that Dr. Ball mentioned earlier, which is renewed every 5 years. As he mentioned, this most recent 7th renewal, the FDA committed that at least one of its enhancements to the Sentinel system between 2023 and 2027 would be in the area of pregnancy safety, specifically with the goal of informing the labeling on safety of medical product use during pregnancy through quickly and accurately identifying potential safety signals that cannot be detected without large sample sizes. It's this commitment that, as we've mentioned, led us to choose the topic for today's training and led us to focus on how we identify safety signals in infants for medications used during pregnancy. The techniques we discussed today are the basis of what will be used in the demonstration projects Dr. Ball mentioned to validate and inform methodologies, which will generate evidence through upcoming demonstration projects. Generating evidence on the safety of medical product use during pregnancy is only a slice of what we do here at Sentinel. Most of the real-world data we use in the Sentinel system comes from health insurance administrative claims data, but the diversity of data sources to which we have access is also extremely important to our ability to generate high-quality evidence. Other sources we regularly access include electronic healthcare record data, patient reports, and state registries. We use our novel suite of analytical tools to answer FDA's questions about drug safety. These questions cover everything from simple descriptive assessments like how many Americans take this drug and what are the characteristics of patients that use this medication, to more complex inferential analyses, answering questions like whether patients using drug A are at a higher risk for a serious outcome compared to similar patients using a different drug. In answering these questions, the Sentinel system's commitment to preserving patient privacy remains at the forefront, ensuring that the absolute minimum data is shared at any point along the way by using a distributed system where all data contributors maintain control and possession of their patient-level data. Eventually, all the evidence that we generate in Sentinel analyses has the ability to be used to take regulatory action, ranging from a simple communication to healthcare providers or the public, making sure that they're aware of any concerns, all the way to potentially removing a product from the market if it's deemed necessary by the FDA. As I've already alluded to several times, there are two key components of the Sentinel system that make all of this possible. It's data in the Sentinel Common Data Model, accessed via a distributed data network, and its analytical tools. It's the combination of both of these components that allows us to efficiently conduct safety assessments across multiple sites throughout the country. So we're going to start by talking a little bit more about the data that we use in Sentinel, specifically the Sentinel Common Data Model accessed through the distributed database. Here at the Operations Center, as you've heard, we are based within Harvard Pilgrim Healthcare Institute, and we collaborate with a number of different organizations, both as data partners and as scientific partners. These collaborations with the Operations Center are crucial to gathering all of the data that we need to generate high-quality regulatory data. Our philosophy within Sentinel is designed to meet FDA's needs for analytic flexibility, for transparency, and for control. The flexibility philosophy essentially means that we are able to maintain the distributed database in such a way that it can accommodate new data domains as we enhance. Typically, our Sentinel Common Data Model is consistently updated to accomplish the purposes that FDA has committed to accomplishing. Transparency, as I mentioned earlier, is another key component. The data in the Sentinel Common Data Model are stored at the most granular or raw levels possible, with minimal mapping to allow complete transparency for individual analyses to perform the analysis as they deem necessary. And of course, we always rely on the data partners and the data contributors to maintain control of their data to ensure that we can appropriately analyze and interpret any data that we receive from them. The Sentinel Common Data Model itself is divided into different tables which have different domains. The core Sentinel tables include those such as diagnoses, demographics, procedures, as well as prescribing tables and dispensing tables. Some data partners, depending on the type of data that they have, also populate data from more clinical aspects like laboratory results or vital signs. Crucial to today's training, we have what we call the mother-infant linkage table, which contains information about deliveries and pregnancies and infants that are the result of those deliveries. We'll get into more details about how this table is generated in a later session. To give you an idea of how the Sentinel Common Data Model can appear in the distributed database, let's take the example of a hypothetical patient. In this case, this hypothetical patient, we can pretend that this patient is a female, and we learn that in the demographic table. In the enrollment table, we learn that this female was enrolled in this particular insurance plan from 2004 through the end of 2018. And this patient has had several dispensings of medications and apparently 2 encounters with the healthcare system. One in 2005, which appears to be an inpatient stay of a few days, and then another in 2006, which is an inpatient stay of 1 day. We see the associated diagnoses and procedures with those encounters. And if we knew a little bit more about the diagnosis codes, we would see that that encounter in 2006 was in fact an inpatient encounter for the birth of an infant. That infant appears in the Sentinel Common Data Model here in the blue text. You can see that this infant was born on the 2nd of May, 2006 as a male who was enrolled from the 1st of June, 2006 all the way through the end of 2018, just like his mother was. You see the associated dispensings, encounters, diagnoses, and procedures for that infant. And then finally, we see that infant and its mother appear in the mother-infant linkage table, telling us that we actually are able to connect those 2 records. And we'll learn a little bit more later about how we leverage that data in order to conduct our safety analyses. Now, if you can imagine this hypothetical patient example on the level of 465 million patients, you can imagine how important it is for us to conduct critical data quality review and characterization for all the data in our common data model. Our data quality review and characterization process is following a number of steps that are heavily involved, not only from the data partners themselves, but also from us here at the Operations Center. We go through a cycle with every time the data partner updates their data to ensure that the data in the Sentinel Common Data Model and in the distributed database maintains of a high enough quality that we can use it for regulatory purposes. Our data quality characterization and review program relies on a few different levels of checks. What we call level 1 checks are essentially things that look within a single table in the common data model to ensure that that table itself is both complete and valid. It looks for things like making sure admission dates aren't missing, or that the admission date is in fact in a date format in the table. We then proceed on to what we call level 2 or cross-table checks, where we're looking for accuracy and integrity across multiple tables, ensuring that if there's a diagnosis in the diagnosis table associated with an encounter in the encounter table, that those dates are lining up, making sure that dates of particular encounters or diagnoses are occurring during a time in the enrollment table when it appears the patient is enrolled in that particular insurance plan. And then we perform level 3 checks, which we call cross-time checks, essentially looking over time through all the data that that data partner has contributed, ensuring that trends are consistent and that we're not seeing unexpected drops. And if we do see anything unexpected, we collaborate with the data partner to understand that and ensure that the data is in fact representing what's actually happening in the real world as the crux of real world evidence. So at the end of the day, after we ensure that that data is of a high quality, we end up with this amazing resource as the Sentinel Distributed Database. In its current form, the Sentinel Distributed Database came online in 2010, as I mentioned in that very first slide. And it now contains about 463 million unique patients who are enrolled in their data partner anywhere from starting in 2000 through 2023. Of those patients, about 342 million have at least 1 day of both medical and drug coverage in the data, meaning we're able to capture their experience across both of those aspects of the healthcare system. And of those, about 113 million are current patients and currently accruing new data in the system. In addition, we have approximately 8 million live birth deliveries that we're able to have in the mother-infant linkage table. The graph that you're seeing is showing the growth of the Sentinel distributed database over time as we gain new data partners and we allow our Sentinel distributed database to represent more and more Americans. Now, as I mentioned, the data in the common data model is crucial to ensuring that we're able to easily access high quality data. But how do we actually access that data? It's through the distributed data network. And a distributed data network is a unique way to perform analyses. So let's talk a little bit about what we mean when we say distributed data network. As I mentioned, data partners are holding their data at their own site in the Sentinel Common Data Model. And when FDA comes to the Sentinel Operations Center with a question, we work together with them to design a study that could answer that question in a scientifically rigorous way. And then we compose a package using our analytical tools, which we'll discuss in a moment. And we distribute that package to every single data partner that's participating in that analysis. Those data partners will run that package at their own site on their own data, and that package will generate aggregate level data, which they then send back to the Sentinel Operations Center after having seen it themselves, having reviewed and approved what is sent back to us here at the Sentinel Operations Center. Again, making sure that patient privacy is at the core of everything that we do. Once we receive all of that aggregated data from each data partner, we aggregate it again so that we can generate a report for the FDA, deliver it to them, and help them with the amount of evidence that they need to answer these important safety questions. So that's the first key component of the Sentinel system. It's data in the common data model accessed through the Sentinel distributed database. The second key component, as we've discussed, is our suite of analytical tools. The Sentinel analytical tools are SaaS programs. These SaaS programs are templated and designed to run against the Sentinel common data model. These tools are pre-tested, they're quality checked, just like the Sentinel common data model data is quality checked. Our tools output standard and customizable reports that can be very highly parameterized for project-specific design elements. And essentially, which tool a particular project chooses to use is dependent process that we'll go through. We first use our analytical tools to construct the cohort of patients that we're interested in answering questions about, and always perform a descriptive analysis. Sometimes, if the question warrants it, we'll proceed on to conducting inferential and/or safety signal identification analyses based on that cohort of population, that cohort of patients that we're interested in understanding. All of the tools are identifying cohorts based either on a medical product of interest or a condition of interest. And depending on what the question is going to determine which tool will be used to answer that question. Our tools can be divided conceptually into two groups. Those tools that can assess only an exposure. For instance, if we're interested in identifying the rate of a particular medical product usage, the rate or prevalence of a particular medical condition, as well as understanding switching between different medical products. We also have tools that can assess associations between exposures and outcomes. We can do things like your standard cohort study, where we are identifying outcomes during follow-up after a particular index exposure. We can assess health outcomes during both risk and control windows, conducting special types of study designs, as well as, we'll discuss extensively today, identifying pregnancies, calculating their duration, and identifying specific medical products of interest during those pregnancies, and choosing whether to follow for outcomes in the mother, the infant, or both. As I mentioned, after you identify the population in which you're interested in answering questions and describe that population, you can choose to access additional modules within the tools to conduct additional analyses. When you want to conduct an inferential analysis, for example, you can use our propensity score module, which estimates propensity scores. We can do both user-defined propensity score models as well as data-driven propensity score models. And then we can use those propensity scores to adjust for confounding in several different ways, some in a later session. And then finally, you can use those models and the propensity scores applied in whichever way you'd like to calculate adjusted effect estimates. You can also optionally choose to conduct a signal identification analysis within Sentinel. What our signal identification module does is that you're able to specify simultaneously a collection of different health outcomes of interest that might be relevant to a particular use of a drug. And then we're able to generate the data that's needed to conduct analyses in a software called TreeScan. And we'll be learning all about that in today's second hour. When you put all of this information together, what the analytical process looks like for signal identification in Sentinel is essentially threefold, beginning with identifying that population and how you want to describe that population, moving through your confounding adjustment methods to make sure that your population is appropriately balanced, and then finally generating the data that we need on several health outcomes of interest in our signal identification module. This is a typical Sentinel analysis for signal identification. And if we had gone through this entire process, as you'll hear in the last session, a case study today, our final step is to ensure that we're committed to public accessibility in reporting. Reporting analyses from Sentinel is crucial, not only to make sure that the FDA can understand exactly the data that was generated from that analysis, but also making sure that it's easily accessible to the public. Our tools not only conduct the analysis, but they also allow us to report it out in a digestible, concise, and easily interpretable manner. And then, of course, making sure that the public has access to everything that we're doing here within Sentinel. And the collaboration between Sentinel and the public is one of the key components to the Sentinel system that we discussed earlier on. The Sentinel Common Data Model is completely available online, both current and past specifications for the Common Data Model itself, for our data quality review and characterization program, as well as different programs that we've put together to transform commonly used pieces or sets of data into the Common Data Model, if that's something you're interested at your particular site. We already have code online, for instance, to transform narrative market scan research databases into the Common Data Model, to transform the Medicaid and CHIP data available from the Center for Medicare and Medicaid Services, as well as to transform the Medicare fee-for-service data available from CMS. It's not just the data that is available online. You can also access our analytical tools online, both our initial module, which identifies and describes a cohort and performs optional analyses, as well as the modules that we use to perform those reporting aspects and generate those concise and easily interpretable reports. In addition to posting these reports online, we can also post the specific analytical packages that were used to generate that report. If you go to the sentinelinitiative.org website, you're able to search through the different analyses that are posted. And in fact, you can even find the analysis that we're talking about today in our final session right there on the website. Overall, the Sentinel system is a robust system wherein we can assess medical product safety for post-market concerns that the FDA has in the United States. I hope that this first session has provided you with a bit of background in understanding what we do here at the Sentinel Operations Center within the Sentinel system. And as we move forward, talking about some more specific aspects of medical product use during pregnancy, I hope that you can rely on this content to help you understand how it is that we're able to accomplish FDA's purposes. I'm going to turn the time now back over to Judy to answer any questions that have popped up. As she mentioned, please feel free to put those in the Q&A box. And I look forward to seeing you again in a little while. Back to you, Judy.
Thanks, Ashley. That was a great introduction. We have plenty of questions that I have tried to answer during the session, mostly for clarification. We still have some remaining questions that I'd like to get answered here live. So I'm going to take the remaining questions and read them out in a little bit to talk about them. So there's a question here about using Medicare fee-for-service data as part of the Sentinel system. And a question about how private folks, so industry or others, might be able to use these data. So right now, the Medicare fee-for-service data that FDA uses in the Sentinel system comes through a data use agreement that is going to be required of anybody that wants to use CMS data. Industry sponsors or pharma are able to obtain their own data use agreement and to obtain what they call a seat in the Virtual Research Data Center, where they can basically apply to use these data for their studies. And so that's an independent process that pharma or industry can go about doing themselves if they would like to use data. If they would like that data to be transformed into the common data model, we provide our programmatic code to do that. And so you can, for example, go to our website and download that code. That will take the data that is inherent in the CMS's VRDC environment. So basically in the file formats that CMS maintains. And you can use that code to translate it into the common data model so that you could answer questions using any of the queries that have already been created, or you could create your own for that data that's formatted in the Sentinel common data model. So looking at some of these other questions, we have a question here about whether the data queries sent to the data partners are general and similar for all the data partners, or whether the data partners are required to write their own analysis codes and to provide the aggregated output. So we have a common data model with a common program. And so what that means is the same identical data query is sent to each data partner that answers the question. Their output is then created, which is identical in structure, and they send that back to the Sentinel Operations Center, and then we aggregate it internally. And then again, as Ashley had pointed out, provide that aggregated report to the Food and Drug Administration. So the data partners themselves do not write their own analytic code to run against their data model. That's all done centrally, and that is all done identically in order to eliminate any unwanted heterogeneity that might occur using different analytic codes. So looking at a couple of these other questions here, we're going to go ahead and take a few more. There's a question here about, and actually I'm going to invite Ashley to come back online to talk a little bit about this question while I go ahead and look through some of the rest of them. So there's a question here about the danger of not detecting unknown confounders hidden in the distributed network that would not fit in the common data model. So I think that what this person is referencing is potentially the fact that there are gaps when data, for example, that might be held in unstructured text or other types of information that hasn't been made it into the common data model, how we account for that. So I want to preview tomorrow. We have an excellent Innovation Center Innovation Day that is scheduled. That's going to be an afternoon presentation. And there are a number of folks who have spent a long time thinking about how to account for that unmeasured confounding using some novel techniques that can try to get at some of those hidden problems that you might see for data that's not been captured in the Sentinel Common Data Model, and think about how to capture that better in the future. So I invite you to attend the Innovation Day that we have scheduled for tomorrow, where topics like this are going to be talked about in much greater length. Okay, I'm going to look at a couple of other pieces here. Does the data in this system contain cost information? The answer is no. Cost information isn't necessary for the safety monitoring for the FDA, so we don't include cost information in the common data model. There's a question here about whether the integrated delivery system partners provide access to all of the EHR data from the data partners, or do they provide a limited snapshot of their EHRs? So the integrated delivery system partners populate various tables in the Sentinel Common Data Model based on where they think their data are fit for purpose. And so that includes vital signs, that includes laboratory results, And thus far, they come straight out of their EHR-based systems, and we utilize those data when we have a question that requires that additional clinical information. And so the data that goes into the common data model is what's represented in their source systems. So in the data quality review, question here is there a way to identify duplicated patients, a patient's record that's included in multiple data partners? So the answer to that is that right now, patients exist potentially in multiple data partners at different points in time. For example, a patient can be represented in a non-Medicare system, perhaps up until the age when they're 64, and then when they're 65 plus, they transition to a Medicare system. Because we don't have a common identifier that we utilize to match patients, we don't have a way to deduplicate them, but we don't believe that they're represented at the same time. So what that means is that you have information for them in one period of time of their life and information in another period of time in their life. Until we have a common identifier and an exchange of information, whether through privacy preserving methods or direct linkage, we aren't in a position yet to be able to link that person longitudinally if they exist in two different data systems. At the same time, we don't expect that they are duplicated for the same period of time. So there's a question here about whether FDA will consider developing other analysis tools from open resource such as R or Python. So I won't necessarily speak for the FDA, but I'd say that generally the FDA is open to considering all analysis tools to have the best sort of tool for the best job. But one of the pieces of running a distributed data network is that we want it to run in multiple different technical environments. And some of our most important technical environments require SAS. And so we're going to continue to develop tools in SAS while some of our most important technical environments require SAS in order for those data to be available and for those tools to run efficiently. So it looks like there's a couple of questions with regard to that. And so I think at this point, we're probably close to time for the questions that we have for this session. So other questions I will continue to answer in the chat. But at this time, I'd like to go ahead and introduce our next speaker so that we stay on time for the day. I'm thrilled to introduce Dr. Shruti Adhamadhyam. She is a pharmacoepidemiologist who was trained at the University of Illinois at Chicago before she came to us here at the Sentinel Operations Center as a research scientist. She focused on determining comparative safety of oral anti-hyperglycemic agents in her dissertation, and we're thrilled to have her present the next talk.
Thank you for that introduction, Judy. Happy to be here. Among other things, it is the FDA's mission to protect public health by ensuring the safety of regulated medical products. Ensuring safety of regulated medical products is a multi-step and continuous process, starting with the detection of medication adverse effects, to confirming them, and from there on taking regulatory action necessary to protect the health of the public. In this session, we will briefly learn about the first part of the process to ensure medication safety, the detection of medication adverse effects. Specifically, we'll talk about how this can be done using the FDA's Sentinel system that we just learned about. Now, detection of medication adverse effects first starts with a step called signal identification. There are several methods for signal identification, but today we will be focusing on one method called TreeScan, which is actually the name of the software that's used, but we're going to use the shorthand TreeScan. So on the agenda for this session, we will first briefly gather some background on signal identification, and then we will spend the remainder of the session getting familiar with the method called TreeScan that can be used for signal identification in the Sentinel system. And we will discuss some key elements to consider when designing a TreeScan analysis in the Sentinel system. So without further ado, let's get started with some background. Now, there were several high-profile drug safety cases at the turn of the 21st century. And around that time, the FDA requested the Institute of Medicine, or IOM, to conduct a thorough assessment of the system of drug safety in the United States. This was in the year 2006. The IOM published its assessment in a report titled The Future of Drug Safety. And in this report, they recommended that the FDA systematically implement post-marketing surveillance methods on a regular and routine basis for the identification of new safety signals. The term signal has a very specific meaning for the regulator, but more broadly speaking, signals are essentially preliminary data about the safety of a drug in humans that warrant further investigation. Now, the agency developed a more rigorous signal management process based in part on this recommendation by the IOM. The signal management process that we have today begins with signal identification, wherein surveillance methods are used to identify a potential safety concern. And once a potential concern is identified, it is then refined, evaluated, and acted upon. Signal refinement entails, among other things, an evaluation of whether the concern identified in this first step of identification could indeed be caused by the drug use. And if deemed valid, such concerns then undergo a detailed assessment of the evidence prior to determination of regulatory action. The focus of this presentation is the first step in this process, signal identification, or the process by which we identify potential safety concerns. Now, there are various sources for the FDA to identify potential safety concerns associated with use of medications. These could be case reviews published in the literature, communication with sponsors, and other inputs. But I want to highlight two sources that can be used to identify such concerns at a population level, or as we call it, quantitative signal identification. The first is FDA's Adverse Event Reporting System, or FAERS, which collects adverse event reports and other concerns from providers and consumers. The collection of these reports is spontaneous and it's voluntary, meaning that reporting is initiated by the provider or consumer. And therefore, the type of surveillance that FAERS can support is called passive. And then we have the FDA's Sentinel distributed database, which Ashley just talked about. And as Ashley described, the Sentinel distributed database consists of longitudinal claims and electronic health record data for around 400 million members in the United States. The type of surveillance that Sentinel can support is active, meaning that it can support proactive monitoring of drug safety that's initiated by the agency. FAERS is a valuable source of safety information for the FDA. It is particularly good at detecting serious and rare events such as liver failure. And it captures consumer and prescriber experience across all products, whether they're available over the counter or via prescription, and across all settings of use. And it offers the regulator a chance to review patient perspectives. However, reporting to FAERS happens when consumers experience adverse events or their providers are made aware of the adverse event experience. So what we have in this database are reports of those who've used the medication and have experienced something. We don't have a sense of all of the individuals who were exposed to the medication, and it's therefore not feasible to estimate risks or rates at a population level. Now this is where the FDA's Sentinel distributed database may serve as a complement to spontaneous reports. In this database, we have data for all individuals within a system that use the drug, whether or not they experience a particular safety concern. And so it's possible to quantify risks associated with drug use at a population level. And because longitudinal medical history is available, we can control for confounders. These are factors that may lead to a spurious association between a drug and a potential safety concern. For example, if you're investigating a concern of a new anti-diabetic drug that may be linked to acute kidney injury, there may be factors that are associated both with the use of the anti-diabetic drug and the occurrence of acute kidney injury, such as age, sex, coexisting conditions, use of common medications, and not controlling for these factors may lead to spurious findings. The good thing about the Sentinel distributed database is that such history is captured in the individual's record each time they interface with the healthcare system. So when we use Sentinel, we're able to quantify risks after controlling for confounders. But data in Sentinel are not without limitations. These data are primarily collected for administrative purposes. They may lack granular clinical information such as body weight or some labs. And in general, the capture is limited to events that are billed to the insurer or those that require a visit to the doctor. And in terms of medications, it's mostly limited to prescription drug use. So more broadly speaking, the Sentinel distributed database captures the experience of the insured population in the US. But I should note that these limitations are not unique to Sentinel. They're common to administrative health databases. Now, as we just learned, both sources of information have their unique sets of considerations. They can be seen as complementary sources for the FDA. The Sentinel system can support active, hypothesis-free signal identification, meaning it can support proactive monitoring of drug safety without necessarily knowing what concern to look for. Within Sentinel, the signal identification process includes systematically evaluating potential adverse events related to the use of medical products without pre-specifying an outcome of interest. That is, we don't need to know upfront what it is that we're looking for in terms of safety concerns. The idea is to pick up on unexpected occurrence of any of thousands of outcomes following drug use and perform a clinical review and a rigorous safety study to further refine and evaluate the concern. Within Sentinel, we can think of the signal identification process in 3 steps. The first is detection. And here we can use data mining tools to look for thousands of outcomes simultaneously for a single drug. What comes out of this process is an alert or a potential safety signal. Once there's an alert, this goes through a step called triage, where thorough clinical review is conducted to determine if what is observed is expected. For example, it may be expected to see an increase in rashes following a subcutaneous injection of a drug, but it might be unexpected to see an increase in heart attacks after drug use. So a lot of clinical judgment is involved here. And so we triage to determine if a potential safety concern detected warrants further investigation. And then we have targeted follow-up, where we can design a rigorous study to evaluate the relationship for the specific exposure outcome pair of interest. For the first step of detection that I just spoke about, where we use data mining tools to look for any number of outcomes following the use of a single drug, there are several techniques that can be used within the Sentinel system. But the focus of our talk today is tree scan-based methods shown here on the slide on the 2nd and 3rd rows. So let's now learn about tree scan. So tree scan, I'm using it as a short phrase, but what we're essentially talking about here is tree-based scan statistics and their use to do signal identification work in the Sentinel system. So the tree-based scan statistics-based signal identification is facilitated with the use of a publicly available software that's known as TreeScan. The first step in our 3-step process of signal identification in Sentinel is detection. And at this step, our basic disposition is that we don't know what concerns to look for. We don't know what new and unsuspected concerns there might be for a given drug beyond what is already known about it. And so that's why we will conduct a tree scan analysis. So like I mentioned, TreeScan is a publicly available software. It's linked on the slide, and this facilitates the use of tree-based scan statistics for signal identification. We can think of TreeScan as a data mining screening tool that generates hypotheses about new potential safety concerns. There are three key features of TreeScan that I'm showing here. First, it is a way to evaluate thousands of outcomes simultaneously. When we initiate a tree scan, we're in a hypothesis generating stage. We don't know which outcomes to look for. So we will look for all possible outcomes, and we can do that simultaneously using TreeScan. These outcomes can be very specific, for example, atrial septal defect, or in groupings of similar enough outcomes, for example, congenital malformations of the circulatory system. And we're able to scan at different levels of specificity because we can leverage a hierarchical tree structure. And it is advantageous to do this because you might not see something at a very specific diagnostic code level. But if you build up to different levels, there may be a signal at a higher level of clinical grouping. Next, it automatically adjusts for multiple outcomes being scanned. So we're essentially statistically testing as many hypotheses as there are number of outcomes available to us, and more if you consider different levels of specificity. And when we conduct multiple tests on the same data set, we run the risk of identifying false positives. The good news is that TreeScan automatically adjusts for multiple hypothesis testing. And lastly, TreeScan is compatible with familiar epidemiologic research methods. So TreeScan is compatible with common study designs such as the cohort or self-controlled studies, and common methods for confounding controls such as matching or stratification. The particular advantage from a Sentinel perspective is that we can leverage some of the existing Sentinel analytic tools, types 2, 3, 4 that Ashley talked about in her first session, to conduct a tree scan analysis in the Sentinel system. The name tree scan is a portmanteau combining the words tree and scan to convey that it is a method that uses hierarchical tree-based scan statistics to do the job. So let's now look at both those components separately. Starting with the tree in the tree scan. The tree in the tree scan refers to a hierarchical tree onto which thousands of possible outcomes are arranged in a hierarchical manner, starting at the broadest classification of the outcome, which is known as the root, up to the most specific classification of the outcome, which is known as the leaf. On the slide here is an example of a hierarchical outcome tree created using ICD-10 diagnostic codes. ICD-10, or International Classification of Diseases, 10th revision, is a diagnostic coding system that is used in the US to code all symptoms and diagnoses recorded in healthcare settings. It consists of more than 70,000 codes that are organized into chapters based on body system and etiology. So the example that I'm showing on the slide here, the root or the broadest classification is diseases of nervous system, which is in the ICD-10G family, and it includes codes G00 through G99. And going a level more specific, we have groupings of multiple codes, such as G43 for migraine, 44 for other headache syndromes, and 45 for transient cerebral ischemic attacks. Now, if we go one more level deep, and if we go to the most specific level, then we are at the leaf, which is an individual diagnosis code in the ICD-10 diagnostic coding system. So, for example, here, G44.011 is the code for intractable episodic cluster headache, and that's a leaf on this tree. Now, any given location on the tree at the leaf or the branch is called a node, and we can choose to do our analyses at one or more of these levels. And so the main thing here is we don't need to know ahead of time that a drug may cause a particular type of headache. With TreeScan, we will be able to evaluate all types of headaches and more, and combinations of them, to see if there is any potential concern, any pattern of unexpectedness anywhere along the tree. Moving on to the scan part of the scan statistic, the TreeScan. So scan and TreeScan refers to the use of scan statistic theory to identify clusters of related diagnosis codes anywhere on the tree that appear in unusually high numbers. So we operate under a single composite null hypothesis here, that there is no increase in event risk for any of the thousands of outcomes along the tree. Once we have a tree defined, we then compute observed events at each node. And this is from our data from our specific population that was exposed to the drug of interest. And we also calculate the expected number of events at each node. And these are generated from a reference time period or a reference population after controlling for confounding factors like age, sex, and other factors. Now, the ratio of the observed events to the expected events is then used to detect any significantly unexpected findings under this null hypothesis. And each significantly unexpected finding is a statistical alert, a potential safety signal that then goes through triage. So to put it in a nutshell, before the TreeScan analysis, you had a drug and no a priori knowledge about new and unknown safety concerns. And after the TreeScan analysis, you may have several alerts or potential concerns that you might want to follow up on. Now, TreeScan analyses differ from traditional studies in that these studies are intended to generate hypotheses. And they do so by looking for associations between a single drug exposure and several thousands of outcomes. Once we narrow it down to a possible list of adverse events, we can then conduct a traditional study, that is a hypothesis-driven assessment of the association between a single drug exposure and a specific outcome. Now, such a traditional study is going to have more rigorous control for confounding because we know what the outcome is. And so we can consider factors that are unique to the specific drug outcome pair. Now, despite these different objectives, hypothesis generating in signal identification work, hypothesis validation in traditional studies, and the different endpoints, thousands of outcomes evaluated simultaneously in signal identification work, whereas a single pre-specified outcome in traditional studies, we will see that the setup of the study itself follows a similar process. And there's similar decision-making in terms of analytic choices for both these types of studies. So this is a diagram to show the steps in study design, comparing the choices we typically take in a traditional hypothesis validation study to what we do in signal identification work using TreeScan. We will use this diagram throughout the rest of this presentation to keep us organized. In a traditional pharmacoepidemiologic study, we start with a research question about a specific drug outcome pair. Then we go through the steps of choosing the right study design, identifying or restricting a study population, identifying outcomes, controlling for confounding, and conducting statistical analysis. We go through the same steps in signal identification work in Sentinel. And so we'll start with the first step. The first step is to choose a study design. In a typical traditional pharmacoepidemiologic study, a researcher may choose a cohort design. Let's see what we do for signal identification work. For signal identification work, there are two designs available in Sentinel. The first is an exposure-oriented self-control design called the self-controlled risk interval design. And it's here on the left-hand side of the slide. That's the diagram. And in this design, we study the incidence of the outcome during a risk interval relative to that in a control interval within the same individual. The risk and control intervals are time periods that are defined in relation to the exposure, with the risk interval being a period during which the hypothesized outcome is caused by the exposure. And this design works in instances where the exposure itself is transient and the outcome is one with short onset and precise onset dates. An example of a transient exposure is a vaccination. It's one shot and it's done, as opposed to chronic medication that you consistently take for a long time. An example of a short onset outcome with precise onset date is a hip fracture. You will immediately require a hospitalization when you experience a hip fracture, as opposed to, say, a cancer or an episode of depression. Now, the neat thing about this design is that because the individual serves as their own comparator, certain characteristics that are relatively stable within the person, like their genetic factors, their lifestyle factors of generally healthy and unhealthy behaviors, smoking, etc., they're controlled for by design without us having to do anything additional for confounding control. But these designs are vulnerable to time-varying confounding. And another thing is in traditional studies with a single pre-specified outcome, the risk and the control intervals are defined according to plausible mechanism by which exposure is linked to the outcome. In signal identification studies, where we look for thousands of outcomes, it's not possible to have a common risk and control interval for all possible outcomes. So what we do is we select an overall observation window. And then what we do is we scan that entire window to see when there's like a peak activity in that entire period. We don't know beforehand what that would be. It could be the first 10 days of exposure or the last 10 days of the observation window, but we test all combinations of the data to find when there could be the most of an issue. All in all, this type of study design is very well suited for the evaluation of vaccine safety. And I see that keeping in mind that it works very well for transient exposures and precise onset outcomes. But it might not work well for drug safety when there's more complexity with confounding related to timing of drug initiation. A design that is preferred for questions of drug safety is the cohort design, specifically the active comparator new user design that's shown here on the right-hand side. In this design, we study the incidence of the outcome among those newly initiating a treatment of interest relative to those newly initiating a comparator treatment. And follow-up starts at the time of the first prescription or treatment initiation. The neat thing about this design is that it mitigates a lot of common sources for confounding by design. First, we choose an active comparator. So you can think of an active comparator as the alternate treatment that's an option for you for a given patient at a given stage in their disease. For example, insulin may not be a good active comparator to metformin in a population with type 2 diabetes, because metformin is first in line of treatment, whereas insulin is last in line or given at a later stage in the course of diabetes. And we know that longer the duration with diabetes, greater the risk of morbidity and mortality. And so we can see how such a comparison brings in confounding. With an active comparator, you essentially select a population that is at similar stages of treatment. And the next thing about this is new users. So we select new users starting follow-up at treatment initiation. And this prevents us from running into something called depletion of susceptibles. This is where there's a reduction in those susceptible to experiencing a particular health outcome of interest because of their prior use of the treatment. And so therefore, this type of design is overall well suited to address questions of drug safety. Now, once we choose a study design, self-controlled or cohort, based on the question that we're pursuing. We further restrict our population to those exposed during a specified period, those meeting enrollment in any study selection criteria that we do to ensure that the population that we have is something that we can observe and characterize well. And that's common to both hypothesis generation and hypothesis validation studies. So after we've chosen the study design and identified or restricted our study population, our next step is identifying outcomes. Now, this is a step where there's a difference between traditional and signal identification studies. In traditional studies, like I've been saying, there's a single specific outcome, and we use a validated algorithm to identify that outcome in the database. Whereas in signal identification studies, using tree-based scan statistics, we have to create a hierarchical outcome tree. I'll bring up the same tree from before. And like I mentioned, this was done using ICD-10 diagnostic codes. But we can use any existing hierarchical coding structure to create our outcome tree. Some examples are ICD-9 diagnostic codes, the Agency for Healthcare Research and Quality's multi-level clinical classification system, etc. And once we have a tree that we can leverage, I want to let you know that we can further prune or curate the tree. So we can ahead of time exclude outcomes that are unlikely to be caused by medical product exposures. These could be things like well-care visits, pregnancy. These could be outcomes that have a long latency, such as cancer, or this could be common and of a less serious or specific nature, such as fever or diarrhea. But I'll note that anytime we want to curate a tree, it requires expert clinical review and judgment, because we don't want to miss any potential safety concerns. So once we've created our hierarchical outcome tree, our next step is to control for confounding. So in traditional pharmacoepidemiologic studies, we typically use propensity scores. What we do in signal identification studies depends on the study design. If we're doing a self-controlled risk interval design, then as I noted before, each patient serves as their own comparator. And so by design, we're holding several relatively stable characteristics like biological sex, genetic factors about them constant across both their windows. We don't typically do anything additional for confounding control with this design. But if there are real concerns about time varying confounding, then that's addressed separately. If we're doing a cohort study, we need to consider some form of confounding control, or we run the risk of generating spurious associations. And we typically do this with the use of propensity scores. Excuse me. So what's a propensity score? A propensity score is a patient-specific probability of being treated with the exposure of interest. We can think of it as a summary score that takes into consideration all relevant pre-treatment characteristics or confounders to predict the likelihood of treatment. So instead of controlling for tens of different confounders, we can estimate one summary score and use that for adjustment. Propensity scores are estimated using logistic regression models with the exposure status on the left-hand side as the outcome and all relevant confounders as the predictors on the right-hand side. Now, this is why we expect that patients with similar distributions of confounders will have similar propensity scores. And so using the propensity score in the analysis to do matching or stratification or weighting will control for various sources of confounding in an efficient manner. But the propensity scores are as good as what we add to it. So the idea here is to add all relevant confounders that we know of and can measure. Now we think about propensity scores and what to put in them differently in traditional hypothesis validation studies that have a specific outcome versus in signal identification studies. So in traditional studies where you have a specific outcome, we have the opportunity to be more thoughtful about the unique confounding structure between an exposure and an outcome. In signal identification work, we have to be more general. What may be a confounder for one outcome may not be for another, and we're looking at thousands of outcomes. So what we do here is we include anything that influences treatment and in general adverse health outcomes. So things like coexisting conditions, burden of comorbidities, etc. So propensity scores, they can be estimated two ways. So there's a traditional propensity score where we use subject matter expertise to come up with the list of confounders that, like I mentioned, can influence treatment and adverse health outcomes. Or we can use a data-driven approach. The data-driven approach is called the high-dimensional propensity score, where we can specify the propensity score model additionally with empirically selected covariates. And these can, the neat thing about this is that it can adjust for unmeasured confounders via proxies. So there might be, I think someone mentioned in the chat that there could be something else going on that doesn't appear in the data as a recorded diagnosis, but there could be other indications of that phenomena happening with the patient that we can use as a proxy to control for confounding. So high dimensional propensity score is a data-driven approach, and it's preferred when the comparator that we have, there's not good enough clinical equipoise. So if it is the case that we couldn't quite find the right active comparator, it may be preferred to use a high dimensional propensity score in that situation. Now, once you have a propensity score, once you've gone through the logistic regression model process and you've estimated a predicted probability for treatment, we can use it several ways to control for confounding. Specifically for signal identification work in Sentinel, we can use the propensity score to do matching or to do stratification. And both these approaches, really what we're trying to do is we're trying to find similar enough people with similar distributions of confounders, and we're going to do our analysis within those similar enough people. So with matching, what we'll do is for every exposed patient, find a comparator patient that is close enough on the propensity score. So we'll set like a caliper of 0.05 and we'll say, within a matched pair, the propensity score cannot be different by more than 0.05 on the probability scale. And so you can imagine in the process of finding these matched pairs, there's a lot of attrition in that you may lose patients who just don't have good matches. And so because we're following up for outcomes within matched pairs, there's some reduced power here. But it does allow for strict confounding control because you're finding as close matches as possible. The alternative is stratification, where we can create percentiles of propensity score distribution, and we'll assign patients to a strata according to the percentile of the propensity score that they have. And what this enables is there's not as much attrition as you would see in the matching, because you're allowing for patients to be similar enough based on the percentile or the decile that you're using. And so you're able to retain a more full exposed and referent population, which increases the power. But that comes, the trade-off there is that the confounding control is not as strict. So we've chosen our study design, we've identified our study population, we've identified our outcomes, we've figured out what to do with control for confounding. The last step is statistical analysis. In traditional studies, we have a point estimate for the specific exposure outcome association and a confidence interval around it. In signal identification studies, what we get is called a test statistic. The test statistic is called the log likelihood ratio. and a p-value to help identify a statistical alert or a potential safety signal. All right, a disclaimer. The next 3 slides are actually going to contain a lot of technical details, but please allow me to walk you through our approach here to identifying potential safety signals. So, how do we know if there is a potential signal anywhere on the tree? For each node on the tree, which may be an individual outcome or groups of related outcomes, we compute observed events, expected events, and something called a log likelihood ratio, which is a measure of the difference between the observed and the expected number of events at any given node. In these types of analyses, we have a single composite null hypothesis that there is no increase in event risk across any node in the entire tree, meaning that at every node on the tree, the number of observed outcomes is in line with what is expected at that node. The alternative hypothesis is that there's at least one node on the tree where there's an increased risk of outcomes. So, how can we test this null hypothesis, and how can we reduce the chance of false positives from multiple testing? We test this null hypothesis using a test statistic called the maximum log likelihood ratio, which is the highest of all log likelihood ratios across every node. And the node with the maximum log likelihood ratio, that indicates the largest departure from null hypothesis on the tree. Now, the distribution of such a test statistic is unknown. So we use a Monte Carlo simulation to calculate a p-value around it in order to make an inference. So the Monte Carlo simulation involves introducing random noise or small variations to the original data set to create multiple simulated data sets. And the simulated data sets are used to estimate the distribution of the test statistic under the null hypothesis. And then we calculate the p-value of that observed test statistic. Excuse me. The observed test statistic, that is the maximum log likelihood ratio in the real data set, is now compared with the maximum log likelihood ratios that we are calculating from simulated data sets that were generated under the null hypothesis. And if the test statistic from the real data set is among the 5% of the highest of all of the maxima, which is our signaling threshold, the null hypothesis is rejected. And we have an alert, a statistical alert for a potential safety signal. Calculating the maximum log likelihood ratio over the entire tree is what accounts for multiple simultaneous tests and helps maintain the overall type 1 error rate or false positive error rate at the level that the user specifies. So we just learned that the log likelihood ratio indicates a departure from the null and that the p-value around it can be used to draw inference about statistical alerts. Now I want to provide a little bit more detail as to how these log likelihood ratios can be estimated. The log likelihood ratio can be calculated using either a binomial or a Poisson likelihood estimator. The binomial or Bernoulli model assumes that outcomes occur uniformly in a population with a fixed probability of belonging to the exposed group. So for example, if referent patients are matched to exposed patients in a 1-to-1 ratio, then half of the observed outcomes are expected to occur in the exposed group under the null hypothesis in this Bernoulli model. And in contrast, the Poisson model assumes that outcomes in the exposed group follow a Poisson distribution, which is based on indirect standardization of outcome rates that are observed in a referent population, so from our comparative group. And the choice of Bernoulli or Poisson model, it's driven by the study design and the choice of confounding control method. So the Bernoulli model is more appropriate for self-control designs, and cohort designs that incorporate like a fixed ratio of persons and observed time in the analysis, whereas a Poisson model is more appropriate when a referent population is available to calculate expected outcomes. The expected outcome counts in the Poisson model, by the way, they can be adjusted for confounding via propensity score stratification. Some simulation studies that have been done by colleagues at the Operations Center and the FDA show that Poisson models demonstrate greater statistical power to detect signals than Bernoulli models. And this is because the Poisson model takes into account background or underlying rates at which events can occur, and this can help detect small changes that might be missed by the Bernoulli model. Another factor to consider to minimize generating false positive signals is to account for temporal trends in general healthcare utilization across the database. This is something that's relevant because we're scanning the database for all possible outcomes. But this sort of consideration into whether or not we account for temporal trends in healthcare utilization, it's specific to the drug and the period of interest under study. So I won't go into more detail there, but I just wanted to note that that's something that researchers have to consider. So to recap, we first learned how to test the composite null hypothesis in a signal identification study using TreeScan. We use a p-value for the maximum log likelihood ratio, which is calculated based on Monte Carlo simulation. We then learned about how we estimate the log likelihood ratio itself. We could either use a Bernoulli model or a Poisson model with or without conditioning to account for trends in general healthcare utilization. Now in this slide, we're going to talk about what are the factors that influence the log likelihood ratio itself and when a log likelihood ratio triggers a statistical alert. So TreeScan uses a statistical alert to identify potential safety concerns by calculating a log likelihood ratio for each outcome, just like I mentioned before. If the log likelihood ratio exceeds a pre-specified threshold at a given node, it suggests that there's a departure from what's expected at that node. And the LLR at each node is, the log likelihood ratio at each node is driven by the distance between observed and expected values, as well as the overall counts of the sample information. So for example, outcomes with larger counts may have larger log likelihood ratios than outcomes with smaller counts, even if departures from the null hypothesis are similar. And so to account for these differences in scale, the log likelihood ratios are plotted against a common p-value that enables comparison across different outcomes. Large log likelihood ratios correspond to small test statistics, which in turn indicate a significant difference between the observed and expected values. And we use a conventional cutoff, one conventional cutoff for p-value is less than 0.05. Which can be used to identify statistically significant departures. So we get an alert, we get a statistical alert when there is a statistically significant departure. And once there is a statistical alert, our next step is to determine if it's also a clinically meaningful alert. And we can do that in the next step of our process, which is called triage. So a statistical alert goes through expert, careful clinical review to rule out all plausible explanations for what is being observed. So researchers on both sides can review labeled conditions, they can review labeled safety concerns, commonly reported adverse events in the literature, and other materials to first see if what we're finding is expected. So for example, that I shared before, rash following a subcutaneous injection, it may be expected, it may be noted on the label. And so the fact that we're seeing that is reassuring, but it's a statistical alert. It's not a clinically meaningful alert. So clinical experts at the agency will then also review patient level data around the time of treatment initiation and event occurrence for better characterization of events and the alerts themselves. And ultimately, a judgment is made, a clinical judgment is made on whether or not the statistical alert warrants targeted follow-up. If it is deemed that targeted follow-up is required, we can design a rigorous study to evaluate the relationship for the very specific exposure outcome pair of interest to minimize any spurious associations from confounding. And so once a concern is identified through this extensive process, it goes further along in the signal management process that we talked about at the very beginning of this talk, which involves steps like refinement, evaluation, and ultimately regulatory action. So this concludes my talk. I know we covered a lot of technical details, so I want to thank you for your patience and audience. Back to Judy for any questions now.
Thank you, Dr. Adamadian. I've been monitoring the chat. We've been catching up on questions from the previous session during this chat, and we've had some that are that right now we don't have any open. They've been answered. And so a couple of themes throughout this this question and answer period, which maybe I'll highlight for folks. With signal identification and particularly with tree-based scan statistics, essentially, there are multiple statistical models, as Shruti has demonstrated today. All of them essentially involve setting up an observed event group and then an expected event group, which is typically based on a comparison population or reference population. It uses familiar epi designs, as Shruti demonstrated, typical cohort designs or a self-controlled risk interval design in order to establish that referent population. And so other than that, I think that's maybe the main theme throughout this session of the questions that were answered. There is a question now about whether slides will be available to download after the presentation. Yes. So this entire session is being recorded and it will be available on our website. Probably wait a few days in order for it to get all uploaded. But the slides will be available, the complete video will be available so that you'll have that information at your fingertips if you'd like. So I'll just wait a few more minutes for our questions potentially to come in. Question here about whether we will be able to get copies of the questions and answers as well. I am going to defer that question for maybe a few minutes to some of our folks who are helping to run this webinar. I'm not sure if the question and answer chat is preserved unless one saves it independently. And so that it might be important to we can see what we can do to save the information for future reference. The previous speaker's name was Dr. Shruti Adamadian for note purposes, and she'll be speaking again later in our agenda today. So while we're looking for whether any additional questions are coming in, I note that we have planned time right now to answer questions until 10:50. And then we have a 20-minute break before we reconvene at 11:10. Because we've published this agenda in advance, I'd like to make sure we reconvene at the time that we've posted for folks who have decided that they really are interested in the latter talks for our agenda today. So if we do break early, we are going to essentially still come back at the appointed time for our third session of the talks today and take a longer break rather than start earlier in order to make sure we accommodate people who've timed their schedule accordingly. There's a question right now that's come in through the Q&A about with the Monte Carlo simulation modeling, is there controlling for multiple testing when using a p-value cutoff of 0.05? So one of the things that is unique to TreeScan is that it uses a single composite null hypothesis test. And what that means is that there are multiple scenarios that are accounted for in that single null hypothesis test. But because in fact it's a single test, it actually is associated, different log likelihood ratios are associated with a particular p-value. And the control for the multiple scenarios, not necessarily the multiple testing, because again, it's a single test. But the multiple scenarios, which is part of the explanation of the composite component of that null hypothesis test, each of those scenarios themselves contributes a log likelihood ratio. And then the test statistic is the maximum over all of those log likelihood ratios. And that's for a singular data set. Then that data set is through a data perturbation process. There are multiple random data sets created under the null, the composite null again, in order to derive that p-value based cutoff. And that cutoff can be anything, it's user specified. So it doesn't necessarily have to be 0.05. You could use a cutoff of 0.01 if you wanted, or 0.05 if you'd like. And so one thing to be really clear is that it's a single composite null hypothesis test rather than multiple testing. But in that composite are multiple scenarios, which is how we end up searching simultaneously for many, many adverse events across a very large tree. So I'm just checking to see if anything else has come in. Some very helpful folks have indicated how one can preserve the Q&A dialogue and the copy and paste into a new Word document. I'm going to just promote that to Answering Live so everybody can see that instruction. Essentially, select all of the Q&A dialogue box and a copy and paste. We will make sure that we do that at the end of our session today, after all of the questions have come in, after our complete program, and then we can make that available on the website as well as a PDF file, just to make sure all the materials are together. There's been a lot of questions today, and there's a lot of important facts in those questions. So we appreciate that folks are interested in retaining a copy of that. And I don't think it will be preserved in the actual video of the session. And so we'll go ahead and we'll see if there's any other questions that have come in. It doesn't look like it, and we will break. By my schedule, but I want to make sure I'm getting a thumbs up from our organizers today. We have a 20-minute break that we had scheduled from 10:50 to 11:10. And so we can take a longer break and resume here our program at 11:10 with session 3 and 4. Feel free to log back off and log back on again, or just stay on. We will hold here until we return again at 11:10. I want to thank our presenters for this morning. Shruti and Ashley, you will see them again later this afternoon. And we hope to be back and see you soon. Thank you so much. Hi, folks, we're back. Thanks for joining us again after our break. I'm going to go ahead and recap what we talked about this morning. So we had 2 great presentations, one on the introduction to Sentinel and one on detecting medication adverse events. Now we're going to invite Dr. Martinez back, and she's going to give us a talk about infant outcomes following medication exposures. I wanted to sort of make sure that people are aware of 2 different organizations and dates before we get started again. So the first relates to our Innovation Day, which is the second part of something that we do annually in the Sentinel system. That's tomorrow at 1 p.m. If you haven't yet registered for it, I encourage you to register. We're going to put a link to the registration in the chat. The second thing I wanted to make sure I mentioned was that in our question and answer this morning, there were many questions about, well, how can I access these data if I am a part of a private company, so a part of a pharmaceutical company or something like that? And I want to make sure people are aware. We'll post this link in the chat as well. There's an organization called the Reagan-Udall Foundation for the FDA, and we work with them when private requests come in to be able to make these data available for private uses. There are others who also might be interested in having these data be available for federally funded research. In that case, we suggest that you send us a request at info@sentinelsystem.org, and we will try to work with you to see what might be available. And so with those remarks, I'm going to go ahead and invite Dr. Martinez back to begin the second half of our program today.
Thanks, Judy. So like Dr. Morrow mentioned, we have one more session before the final session of the day. And really our goal with this third session is to help everyone get on the page with where we can apply the methods that Dr. Adiman strictly discussed in the second session, but instead focus specifically on the context of medication use during pregnancy when we're looking for potential adverse effects among infants. So in this third session, we're going to give some context about why this area is such a crucial one in which to perform signal identification and how Sentinel fits within FDA's framework. And we'll also talk some more about details about why Sentinel is well suited to be used in this way, focusing on its ability to identify pregnancies, to capture medication use during those pregnancies, and to detect infant outcomes. As we discussed this morning, FDA has shown consistent commitment to enhancing the Sentinel system and its ability to study pregnancy safety in the post-market setting. Sentinel's main goal in signal identification is the same as FDA's goal when they're working with sponsors to institute post-market requirements and commitments, and that is to inform the labeling of drugs while used during pregnancy, and to detect and evaluate safety signals quickly and accurately. Now, this population of pregnant patients is not an insignificant one. In 2021, there were more than 3.5 million births, equating to about 56 births per 1,000 women of reproductive age. And most recent estimates suggest that 9 in 10 of these women take a medication during their pregnancy. If you or someone you know is one of these women, you'll know that all sorts of questions arise when the time comes that a medication during pregnancy becomes necessary. Why is that? Well, essentially, it's likely in part due to the fact that when one is taking a medication while pregnant, they have 3 aspects to consider. Just like any patient, a pregnant mother often finds herself thinking about how the medication might impact her own health. We call these maternal outcomes, and they can include things like medications causing high blood pressure or something called gestational diabetes, gestational hypertension or gestational diabetes. However, the mother might also find herself thinking about how that medication might impact her pregnancy. Pregnancy outcomes can range from slight changes in the progress of the pregnancy or perhaps premature delivery. And finally, mothers often wonder what effect a medication can have on their infant. Could it cause a malformation during development that manifests after birth? Could it cause slight changes that result in developmental delays later in life? And unfortunately, the answer to a lot of these questions is often we just don't know. And the reason we don't know is because the data just aren't there to make evidence-based decisions. Starting as early as the pre-approval setting during drug development, pregnant people are often excluded for ethical reasons due to uncertain safety in general populations. And this means that data generation is often left to the post-market setting. Unfortunately, we know that fewer than 5% of post-market clinical trials actually include pregnant patients. So that leaves us in a situation where we have to look to other data sources. FDA has numerous methods for assessing safety in the post-market setting, including registries set up specifically to track medication use in pregnant populations, as well as their own adverse event reporting system, which we've mentioned before. But unfortunately, each data set has its own limitation. And one limitation that's common to each of those that I've mentioned is that they don't tend to have very many pregnant patients in whom we can identify medication use, much less information about potential negative outcomes in infants. And that's where Sentinel can step in and help fill in some of the gaps. Just as we've seen it do in several other contexts, the Sentinel system can enhance FDA's safety surveillance program here in this area too. But in order to be a successful data source for this purpose, there are 3 things that we need to make sure the Sentinel system can do before we can feel comfortable relying on it for signal identification in the regulatory context. First, we have to make sure that we can adequately and accurately identify pregnancies. Second, that we can capture not only the presence of a medication, but also the timing of that medication with respect to the pregnancy. And finally, that we can sufficiently capture any potentially adverse or negative effects that could be unexpected, whether that's in the mom, the pregnancy, or the baby. So in this third session, we're going to go through each of these and talk about what Sentinel has to offer, starting with that pregnant population and how we identify pregnancies in the Sentinel system. When we go about constructing a pregnancy episode, we use something that's called the Medication Exposure in Pregnancy Risk Evaluation Program algorithm, or the MEPREP algorithm, which has previously been validated to identify live birth deliveries among patients using administrative claims data and has been updated for the ICD-10 era. And so essentially what we do is we're looking for diagnosis and procedure codes that are indicating that a live birth has taken place, and then using diagnosis codes that indicate gestational age to back calculate a potential start date for that pregnancy so that we can construct an entire episode for that pregnancy and its duration. Let's just suppose, for an example, that we identify a live birth delivery on, we'll just say June 1st, 2010, using a particular diagnosis code and a gestational age code that appears on the same day as that inpatient delivery. What we're going to do is we're going to say, knowing the gestational age on the day of delivery allows us to back calculate a potential pregnancy start date and then construct that pregnancy duration in between those dates so that we can then determine, with respect to both the pregnancy start date and the delivery date, when each trimester was occurring during that pregnancy. We can also assess pre-pregnancy and post-delivery periods with respect to the pregnancy's duration. Within the Sentinel distributed database as it exists today, we've been able to identify about 8 or 9 million pregnancies with a live birth delivery from 2008 to 2022. And among these deliveries, we know that we can identify about 4.3 million after we apply what are often considered standard enrollment requirements that we impose in any sort of observational study that we conduct. We can add pregnancies back depending on how we specify our study, how long we're requiring pregnant mothers to be enrolled in the data source prior to their pregnancy or during or after their pregnancy. And in the graph on the right, you can see the impact that reducing those enrollment requirements can have on the number of pregnancies that we can capture, with the lighter blue portion of the bars showing the amount increase we're able to find when we relax those enrollment requirements. You can also see an interesting uptick in the middle of our data period, and this is really just to demonstrate the impact that adding data partners can have on data in the Sentinel system. This is as a result of the addition of a data partner. And so we can see that as we continue to enhance and develop and further the Sentinel system, we can have access to more pregnancies and in close relationship with those data partners, develop methods to link the mothers who are pregnant to their infants. Because we know that we can identify these pregnancies ending in live birth deliveries within the Sentinel system, then we move on to asking ourselves whether we can identify medication use during those pregnancies and the timing of that medication use. So how do we do that within Sentinel? The FDA really is committed, as I mentioned before, to enhancing the Sentinel system as it relates to pregnancy safety. These enhancements are part of their most recent commitments in the Prescription Drug User Fees Act, 7th edition. And they have committed, as we talked about at the very beginning of the day, to conducting demonstration projects wherein we can show how Sentinel can identify these medications and perform signal identification. Specifically, there are demonstration projects that require us to show that we can identify potential safety signals in medications that are highly used during pregnancy or highly prevalent, as well as for those medications that are more rare or aren't commonly used during pregnancy. So we need to be able to demonstrate that we can do signal identification in both contexts of medication use. So when it comes to finding those medications during pregnancies, the first thing we have to do is determine how often they're occurring and how many pregnancies are exposed to a particular medical product. The way that we do that is we construct drug treatment episodes after already identifying a pregnancy. What we're seeing on the slide is an example pregnancy that we can see has a particular duration. And below that in the purple is just an example of a particular treatment pattern that we might see in the data. This is drug A. And so what we're seeing is that this particular patient is taking drug A for a short period of time before pregnancy, a longer period of time immediately prior to pregnancy, and then a short period of time immediately after pregnancy. And so this case, the medication A did not occur at all during the pregnant period. And so this pregnancy would be considered unexposed to medication A. Let's look at another example, medication B. In this case, the drug treatment episode spans the entire period, pre, during, and post-pregnancy. And so in this case, the pregnancy would be considered exposed to drug B. And then just as a final example, we have the case where a particular medication C is showing up at some point during the first trimester, as well as at some point during the second trimester. And so this pregnancy is considered exposed, but only during the first and second trimester. We can even get this down to the level of gestational week. So we can look at medication exposure during pregnancy at a very granular level within Sentinel. After identifying those medications, then it comes down to asking ourselves, what might be good products to assess within the Sentinel system? What are those highly prevalent products and what are those very rare products when it comes to use in pregnancy? And so FDA has already done some work to try to understand what's going on with medications in pregnancy. We already know that drug sponsors can be required to do certain things in a post-market setting. They can have post-market requirements or commitments that require them to conduct clinical studies, observational studies, maintain a pregnancy registry, or perform other actions in order to get additional safety data that the FDA needs in the context of pregnancy safety. But FDA can also solicit the Sentinel system to determine if they can get that information in this way. And so what they've done is they've looked at 249 products that have a post-market requirement, commitment, pregnancy registry, or clinical trial currently ongoing that is related to pregnancy safety. And they've asked us to assess the frequency with which those medications are identified during pregnancies. There are 249 medical products that they've assessed, and we're going to look at it in two different ways. The first way we're going to look at it is by identifying those medical products during any pregnancy that ends in a live birth delivery in the system. That's what we're seeing here on this chart. We're seeing, according to the number of pregnancies that are exposed, how many of those 249 medical products that we know are lacking safety information in pregnancy are actually occurring. So the first bar on the left is showing us that 59 out of the 249 medical products that we're concerned about are not used in any of the pregnancies ending in live birth deliveries that we were able to identify. And as you continue to the right, you're seeing the number of medical products that are exposed in that many pregnancies. And so in a summary way, we can say that 43% of those 249 products are used in fewer than 10 pregnancies. Almost 3/4 are used in 500 or fewer pregnancies. And based on previous validation work, we can estimate that we need at least 4,000 exposed pregnancies in order to conduct a signal identification analysis that's adequately powered to detect some of the unexpected outcomes that we see in the infant population. And so if we use that as a cutoff, we see that 31 out of the 249 medical products of concern are potentially prevalent enough to conduct a signal identification analysis and have adequate power. Now, of course, this is just looking at a single medical product, and often we conduct these studies across classes. So it's very likely that, in fact, there are more medical products than 31 out of 249 that we can assess. But this really is FDA's first look at understanding how these products that we know are lacking safety data in pregnancy are being used during pregnancies. But I mentioned we looked at this two different ways. The second way that we, looked at this was by restricting our definition of pregnancy to only those pregnancies where we were able to link a mother to her infant. And we'll talk in just a second about exactly how we do that and how the data partners work really hard to make sure that linkage is of a high quality. But does that restriction change the medications that we're able to identify? In the second chart, you can see that essentially it's the same shape. Our overall size and the number of pregnancies that we can identify is slightly smaller. It's about 3.1 million instead of 4.3 million, because we're only looking at those pregnancies that we know are linked to an infant and that we can assess the outcomes in that infant, linking to the pregnancy exposure. In this case, when we look only among pregnancies linked to an infant, we see that, again, about 45% of products are used in 10 or fewer pregnancies. 77%, slightly higher, are used in 500 or fewer, and only 28 instead of 31 products are used in 4,000 or more pregnancies. So we're continuing to do this work, and as Dr. Ball mentioned in the beginning, there's even a whole workshop dedicated to exploring this and choosing products and how we're going to perform these demonstration projects. So this is very much a work in progress, but hopefully it helps, the data that we have so far helps everyone understand a little bit more about how we're identifying those pregnancies and medications within the Sentinel system. And that final component that we talked about was being able to identify adverse outcomes in infants after we're using medication during pregnancy. Now, of course, we've discussed before that adverse outcomes can happen not only in infants, but also in the mothers and specifically with regards to the pregnancy. But for the purposes of this training, we're focusing on those outcomes that happen in infants. And the population in which we're identifying outcomes can influence the study design that we end up setting up. So just keep that in mind as we go into the fourth session. The study design choices are very much influenced by the fact that we're looking in infants for these outcomes. Now, because we're looking at infants, we're going to rely on those pregnancies that are identified in that mother-infant linkage table. Within Sentinel, we use the mother-infant linkage table to identify the deliveries that ended in a live birth, to identify those linked mother-infant pairs, and to identify certain infant characteristics. And an analysis that uses the mother-infant linkage, or MIL table, to identify deliveries can choose how they want to define that pregnancy, whether they want to restrict only to deliveries that are linked to infants, whether they want to include all deliveries, whether they want to further restrict that, for instance, to only singleton infants, as is often the case for inferential analyses. But ultimately, there's a lot of programmatic and query or question-specific determinations that can be made after choosing to leverage the mother-infant linkage table. Just as the rest of our data is highly quality assured and controlled, so is the mother-infant linkage table. Essentially, what happens is the Sentinel Operations Center sends out the package to the data partners to identify these deliveries that have live births. After doing that and making sure that the data partners have high quality assessment of these deliveries, the data partners themselves go on to perform the linkage and do some iteration to assure quality with the Sentinel Operations Center before that table finally goes live and is available for answering FDA's questions. Now, as far as identifying those deliveries goes, the data partners are able to record such information as the admission date for the delivery encounter, if it was within the healthcare system, the patient ID, their date of birth, their age at delivery, what type of encounter it occurred at. And they also impose different restrictions on the mothers that are entering the table. You can see in this slide that we impose both coverage requirements as well as delivery washout requirements to ensure that during that period where another delivery shouldn't be happening, that in fact we don't see one. And again, these are all done to ensure the quality of the data that we're using for regulatory purposes. As far as identifying infants goes, the data partners are able to, again, record those dates of birth, the sex, and the date that the infant is enrolled, and choose whether they want to impose any coverage requirements, for instance, requiring that the infant be enrolled in the data source for a particular number of days over a particular time period. Finally, when it comes down to it, we can see that the data partners can choose, based on their available data, how to actually link the deliveries to the infants that they've identified. Some data partners use things like subscriber numbers, which means that there's a common ID number in a whole family that they can leverage. Others are matching based on last name and address, maybe if they have access to a birth certificate or a registry, or various other methods. And we're recording exactly how that linkage is being made within the mother-infant linkage table itself, so that on a question-specific basis, you can choose exactly which linked deliveries you'd like to assess. And again, this is highly quality controlled, and all of the data that went into and was generated from establishing this process is available on the Sentinel website. Currently, the mother-infant linkage table has a linkage rate of about 75% in containing about 10.7 million live birth deliveries, showing you that about 8 million of those are able to be linked to an infant. Just as a note, you can see that there are more infants than mothers in the table, and this is due not only to the fact that a mother can have multiple infants, but also because, as I noted earlier, a lot of times data partners will actually require a certain amount of coverage or washout in order for a mother to make it into that table to be of high enough quality for an analysis for the FDA. And we don't often apply those same restrictions on the infants. There are several reasons that a particular site or a particular data partner's linkage rate might be different than another partner's. Sometimes it's because certain data partners have a higher likelihood that a mother and an infant are on the same plan, that they could even have the same family subscriber ID. Other times, like I mentioned, it's because we require a relatively strict coverage requirement for the mother. And then again, we have a relatively low tolerance for potentially incorrect linkages. And this means that really if there's any uncertainty in the linkage, we request that the data partners do not perform that linkage, so that those that are present in the mother-infant linkage table, we are quite certain are in fact mother and her infant. And so I hope with this session, we've been able to convey that the Sentinel system can adequately and accurately identify pregnancies ending in live births, that we can pinpoint the timing and the presence of medication use during those pregnancies, and that we have sufficient linkages to be able to identify the adverse outcomes in the infant population. After this session is finished and we're done taking questions, we'll then move on to talking about how we've actually done this using a case study in the last session. So with that, I'm going to turn the time back over to Judy for questions and comments. Thanks.
Hi, folks. Just looking at some questions that have come in the chat, particularly related to the mother-infant linkage. Since we have a little bit of time, I'll go over some of them live. There's a question about whether or not basically a pregnant person who gives birth to multiple infants, if multiple of those infants are linked in the mother-infant linkage table. They are. So the data are still linked. However, analytically, typically, studies are done limited to singleton infants, and that's to prevent the mother's exposure from being counted multiple times. And so just want to distinguish between the data that are available in the data table, which is more complete than what could be used in analytics. The analytics is where people narrow their definitions to exactly what they want, and that's where we see oftentimes that singleton limitation come into play. Additionally, there's a question here about how long data are available for the linked infant. So the linked infant is an independent patient in the data set, and that data are available as long as that patient is enrolled. And so for our infants, we have some infants that are enrolled for a very long time following their birth and stay within the same medical system. We have other infants that change systems. So it's variable depending on the particular infant, but basically they're an independent patient in the data set. And so there's not any limitation of that data as long as those data are available. Some question about whether any of the data provided includes breastfeeding or lactation information on mom. And the answer is no, not at this time. Breastfeeding or lactation information could be gathered through patient survey or some other type of patient-reported outcome. And we do have places in the data model to contain some of that information, but there hasn't been a formal effort to go and undertake that. Additionally, for our electronic health record partners, there may be data on breastfeeding or lactation contained in clinical notes, which is typically unstructured, and we could think about, and our Innovation Center colleagues have thought a lot about how to structure that data for use potentially in studies. And breastfeeding and lactation patterns are a good candidate for that type of information. A question here, is there another table for non-live births or miscarriages? It would seem this table can't be used to identify drugs that induce fatal birth defects or abortions. And so there isn't a dedicated table for non-live births or miscarriages, but non-live births and miscarriages can be identified through validated algorithms. We did one ourselves in the Sentinel system a couple of years back. Susan Andrade led that work. I saw her today on the number of attendees, and that work is done identifying a validated algorithm that then can be used to identify non-live birth outcomes. So although we don't store that information permanently, we certainly can use those validated algorithms to identify the non-live births or miscarriages and then use that information in further study. A question here, can you comment on the linkage to death certificates? Yes. So we have several partners in our large distributed database. They happen to be the regional data partners that often link to a state-based death registry. And they bring in information from death certificates into the Sentinel distributed database. We have a death table and we have a cause of death table, and that information is brought into that table. There is also a fetal death registry that's available at a very few of our data partners that's included included in that information. So right now, we are pursuing in our Medicare and Medicaid data partners a introduction of data from the National Death Index into the data system. The National Death Index is typically about 2 years lagged, but it does include death and cause of death information for individuals that in this case would have been covered by Medicare and Medicaid. We expect that to be available sometime within the next year. So I'm looking to see if there are any other questions that have rolled in. Are the validated algorithms that you use publicly available for use by other researchers? The answer is yes. So all of these validated algorithms are essentially published in PubMed. So if you have access to medical literature in your organization, there are a number of different algorithms that have been published that are out there. And those algorithms are typically available with supplemental indices that indicate which of the codes that are utilized for the various algorithms in those papers. So I encourage you to do a standard literature search in PubMed to find the algorithms. There are many to choose from, frankly, in the ICD-9 and the ICD-10 era for your particular outcome of interest, be it a live birth delivery or a non-live birth delivery or non-live birth outcome. Okay, checking to see if anything else is coming in. A question again about the slides being available. Yes. So after the conclusion of our program today, all of the slides will be available. Our video will be available. We're recording and we also will make the Q&A available to folks that will be on the website, www.sentinelinitiative.org. So I'm just going to wait a few more minutes. We have some time available in the program to continue to take questions before proceeding with our last talk of the day. So I'll go ahead and take a look at that. And then for questions I've answered live, we're trying, since we're going to make a transcript of the Q&A available, we're going to try and make sure we answer them as well in the Q&A. So you have record of that if you choose to go and seek that out. So I'm not seeing any new questions come in. And so I feel we're ready to proceed to the last talk of our program today. This is our case study example. I'd like to invite Dr. Adamadian back up to talk to us about fluoroquinoline use in the first trimester of pregnancy and subsequent adverse infant outcomes. And with that, I'll give it over to Dr. Adamadian to continue.
Thanks, Judy. And hello again. So this time, I'm excited to share with you a practical case study evaluating first trimester exposure to fluoroquinolones. Now, this case study was recently published in the Journal of Pharmacoepidemiology and Drug Safety, and I've listed the citation on the slide if you would like to refer back to it at a later time. So we have covered a lot of material today. Let's take stock. We first learned about the background on Sentinel and how it came to be. Then we learned about how it works with its common data model and validated analytic tools. We then reviewed how we do signal identification studies using tree-based scan statistics in general. And now Ashley just talked about the infrastructure that we have to study infant outcomes following maternal exposures with our mother-infant linkage table. So now it's time for us to put all these together and demonstrate them in action, in practice, via this case study. So the purpose of this case study is to demonstrate the capabilities of using the signal identification system that we've built in Sentinel using TreeScan for surveillance of adverse infant outcomes following maternal drug use during pregnancy. The case study that we've selected is one that compares exposure to fluoroquinolones versus cephalosporins, both classes of antibiotics, exposure to these drugs in the first trimester of pregnancy. We selected this case study because we know ahead of time that both these drugs have no known associations with major congenital malformations. So we did not really set out to identify any new statistical alerts or potential safety concerns here. And what we actually hoped to do was to demonstrate minimal number of false positive alerts generated from this process. So we're going to go back to these diagrams to keep us organized. Starting with the first step of detection in Sentinel signal identification process, where we will use data mining tools to evaluate all possible infant outcomes following first trimester exposure to fluoroquinolone or cephalosporins. And we're going to go through each of these steps of setting up a study in Sentinel. But this time I'm going to add a little bit more detail, practical detail. So the first few steps of choosing a study design, identifying a study population, identifying outcomes and confounding control. All of this is happening within Sentinel's analytic tools. So we'll use Sentinel analytic tools to generate an analytic data set that contains observed and expected events following first trimester exposure to either of these antibiotics. And once we have that analytic data set, we're then going to go to the publicly available software, which is TreeScan, which will then generate the log likelihood ratios that I talked about in my session at each node, and will calculate a p-value, which will help us to make an inference. So it happens in two parts. So we're leveraging the Sentinel analytic tools. We're creating an analytic data set. We're going to a publicly available software to give us a p-value to make an inference. So let's go through each of these steps in context of how we would do it in Sentinel. The first step is choosing a study design. What we have is a drug safety question. We're interested in the safety of fluoroquinolones and cephalosporins used during pregnancy. So given this is a drug safety question, we chose to do a cohort study. Our next step is identifying a study population. So first starting with our exposures. So we have fluoroquinolones, which are a class of antibiotics that are used to treat a wide variety of infections. We do know that it crosses the placenta, but there are no known teratogenic effects for this drug. And on the other hand, we have a comparator, cephalosporins, which are also actually fairly similar in terms of their use in practice. So they're also a class of antibiotics used to treat a wide variety of infections. They're also known to cross the placenta, but there are no known teratogenic effects. So what we've created here is a good active comparator new user setup. This is important, like I told you, it's important to have an active comparator to mitigate some of the common sources of confounding in cohort studies designed to evaluate drug safety. And we know ahead of time that there are no known associations for major congenital malformations following the use of these drugs. So we know upfront not to expect any new statistical alerts that are potential safety concerns. So we've got our active comparator new user set up. We've got our cohort study. We're next going to think through an outcome tree, a hierarchical outcome tree. So in this study, we created outcome trees based on ICD-10 diagnosis codes. So this is similar to the example from my prior session. But what we did here was basically study major malformations or chapter Q codes that are listed on the slide, and certain gestation and birth weight conditions that are chapter P codes listed on the right side of the slide. So we're showing a sample structure with the chapter Q and chapter P codes, and you can see that not every chapter within the ICD-10 system is organized in nearly the same way. So we can see, for example, chapter Q codes, which are for congenital malformations and deformations. There's increasing levels of specificity down to the leaf level. When you go, there's like laterality in the exact position where the malformation occurred. The chapter P codes, on the other hand, go down to about the level 4 and aft, and that's the most specific level there is for the chapter P codes. So what we did further, so we used ICD-10 diagnosis codes. We knew we were interested in major malformations and certain other conditions. So we curated the tree. So we took out codes for minor malformations, genetic conditions, and chromosomal abnormalities that we know we're not interested in. And we did this using some guidance from the World Health Organization on how to identify these minor malformations. And then the last bit I will let you know is that we chose to do hypothesis testing at levels 3, 4, and 5. We did not choose to do hypothesis testing at the most specific leaf level because, like I said before, those codes are primarily used to designate the exact location of the malformation. So levels 3 through 5 will give us the story. So our next step is controlling for confounding. So given this is a demonstration and a case study, we did both. We did propensity score matching as well as propensity score stratification within the cohort study. So for the propensity score matching in our main analysis, we did a fixed ratio match, a 1-to-1 match. So each fluoroquinolone user was matched to a very similar cephalosporin user who had a nearly identical propensity score and therefore nearly identical distribution of baseline characteristics. But we knew ahead of time that doing 1-to-1 matching, while it gives us a strict confounding control, we also lose patients in the process. And so we did a sensitivity analysis where we increased the matching ratio to find more controls for each exposed patient. We did a 1-to-2 and a 1-to-3 matched sensitivity analysis. And then we did the stratification. We used the propensity scores created to stratify the cohort. And the percentiles that we created were actually deciles. So we created deciles within the full populations, and then we calculated the expected counts within each decile of the propensity score. So that's how we thought through the confounding control. I'm going to actually go back to study design, which we can think of this both as restricting our population as well as something that is unique to the confounding control that we chose. So I'm going to go through our study design here. So we used the Merative Market Scan Research Database, which is similar to the Sentinel distributed database in that it captures longitudinal patient level information on enrollment, utilization, et cetera, for about 100 million individuals in the United States. That we have in-house here transformed into the Sentinel Common Data Model. But this is not the Sentinel distributed database. So this is not the entirety of what we have access to if we choose to pursue this as a research question. So we created a cohort of singleton live birth deliveries that occurred between the periods of October 1st, 2015 through March 31, 2019, which at the time of the conduct of the study was the most recent data available. So if we notice one thing about this period is that it is in the ICD-10 era. Now this is important because the outcome tree that we chose was in the ICD-10 era. as Ashley has shown, like the wealth of the data that we have spans across both ICD-9 and ICD-10 eras. So this is a decision that we do have to make. If we do decide to conduct a study including both ICD-9 and ICD-10 eras, we'll have to do a lot of work curating that tree and ensuring the ICD-9 and ICD-10 mapping process is done adequately. There's a lot of clinical judgment involved in that. So for this demonstration purposes, we stayed within the ICD-10 era. Okay, so singleton live birth deliveries that were, we have a linked infant for the delivery occurring in this ICD-10 era, where the age of the mother at the time of the delivery was between 10 to 55 years old. So that's our base population. And from there, we added on several other requirements to ensure that we're able to observe and characterize our population well ahead. So first, our mother-infant pairs were required to have 391 days of continuous enrollment in a health plan with medical and drug coverage prior to the date of delivery. Why 391 days? Well, the longest duration of pregnancy within this scheme is 301 days. And then we add on a 90-day pre-pregnancy window, which we want because we want to observe, we want to observe pre-pregnancy characteristics in these women. So if you want to observe something in a record, we need to ensure that the patient is enrolled, because they will only interface with the healthcare system when they're enrolled. We then used a washout to 273 days prior to delivery. This is just in case that we observe any non-plausible outcomes where the codes, which we know are imperfect to identify deliveries, are implausibly close to each other. So that's why we have that washout. And then we excluded mother-infant pairs with exposure to known teratogens in the first trimester. Known teratogens we know will have major congenital malformations with that. We wanted to just focus on adverse consequences of exposure to fluoroquinolone and cephalosporin used in the first trimester. And then for our active comparator new user setup, we ensured that the patients that we, the mother-infant pairs that we selected were naive to both cephalosporin and fluoroquinolone use in that first trimester before being selected. So they had to be true new users when they index into the cohort. The period during which we evaluated the exposure is first trimester. So this goes from the estimated start of pregnancy to I think 90 days after the estimated start of pregnancy. The estimated start of pregnancy, like Ashley described, is calculated based on gestational age codes that are visible to us around the time of delivery. Outcomes, incident infant outcomes, using both information from maternal and infant records in the time span that is the date of delivery through 180 days after delivery. So if we're interested in adverse infant outcomes, why did we look for information in both maternal and infant records? We did that because maternal, there's an expected gap between date of birth and enrollment of infant in the insurance plan. And so that's why we included maternal records, because unless the infant enrollment goes live, all of those diagnoses are captured in the mother's record until that point. So that's why we included both maternal and infant records when looking for outcomes in the post-delivery window. And then we wanted to make sure that the outcomes that we were seeing were incident outcomes, meaning they weren't already ongoing conditions at the time of delivery. So only the first code from the groupings in level 3 of the tree that occurred during the washout period were considered incidents. So if you've had any evidence of any other Q code in that level 3 in the washout period, we wouldn't count that as an incident outcome. We do this to keep things clean, to like ensure that we're really picking up new safety concerns and not something that's been ongoing. And because we're looking for all possible outcomes, we could have identified multiple incident outcomes for each mother and infant pair. So this is the design that we have for the matched cohort study. For the stratified analysis, it's the exact same design with one minor modification, and that is that we add on a 180-day post-delivery enrollment requirement. So we further require patients to have, mother-infant pairs to have not only the 391 days prior to the delivery enrolled in the health plan, we also need them to be enrolled in the health plan with medical and drug coverage for the 180 days post-delivery. And the reason we do this is to ensure that the exposed and the referent patients are followed for the same duration. This is something that happens by design in our matched analysis, wherein Sentinel is conditioned within the matched set, such that if one pair is lost to disenrollment during follow-up, the other patient in the pair is also censored at the same time. So that's something that's taken care of in our matched analysis, but in our stratified analysis, we'll need to enforce that post-delivery enrollment requirement. So everything that I showed you in these two slides is what is the information that we need, the basic information that we need to set up the cohort in the Sentinel analytic tools. So things like 180 days, 391 days prior to of continuous enrollment prior to delivery, and 180 days of continuous enrollment post-delivery. These are what are known as parameters in our Sentinel analytic tools. And so we'll populate this information in the tools such that the program is run the exact same way in every data partner that participates, which in this case is just MarketScan, but I'm just making a point here about how we do this when we go to the Sentinel distributed database. Continuing on in our analytic decisions to control for confounding in this case. So like I mentioned before, a key factor here is the propensity score is only ever as good as what we put in it. And given we're scanning for thousands of outcomes, we know ahead of time that it's not possible to achieve perfect confounding control. So what we aim to do here is include enough factors that tend to influence severe maternal morbidity and mortality. So we have a general propensity score model, which includes a list of variables that are things like conditions in the obstetric comorbidity index, pre-pregnancy health utilization and screening behaviors, and pre-existing conditions that may tend to predict severe maternal morbidity and mortality. We have another propensity score model that further added on indications for fluoroquinolones and cephalosporins. There's a paper that's cited in the footnote here that provides a justification for why we should do this in signal identification work. So we added on indications for fluoroquinolones and cephalosporins, which in addition to the screening behaviors and the pre-pregnancy characteristics I talked about, were things like urinary tract, specific diagnoses for urinary tract infections, lower respiratory tract infections, etc. Things that may have gotten folks their fluoroquinolone or cephalosporin prescription. And then lastly, we used a data-driven approach to select 200 variables that are associated with the exposure. So this is the high dimensional propensity score, which in addition to what we know from measured confounders, we may also pick up on additional unmeasured confounders through proxies. So when did we assess each of these factors that went into the propensity score model? So there's 3 different windows. So for pre-existing conditions, we looked for these in the 90 days prior to estimated start of pregnancy to the end of first trimester. There's healthcare utilization and screening, which is a true pre-pregnancy characteristic in that we looked at it in the 90 days prior to the estimated start of pregnancy. And for the indications in the model with general factors and indications, the indications were ascertained in the 7 days prior to the start of exposure, including the day of the exposure. And factors like age were ascertained on the index date, which is the date of the delivery. So one thing I'll note here is we typically like to keep our confounders pre-treatment characteristics, but one factor here is those pre-existing conditions where we allowed or where we observed these conditions through to the end of the first trimester, which is when we were also evaluating exposure. The reason we did that is because it gives this population especially a chance to have their conditions up in their medical record, if I may. They come in for their first prenatal appointment, and that's probably when we'll start seeing some of the history show up in the medical record. If we don't do that, we might not catch pre-existing conditions because of the typical healthcare utilization of the demographic here. So we've done now all the things that we need to do to get our Sentinel analytic data, Sentinel analytic tools to give us an analytic data set, which includes observed and expected events at every node on the tree that we identified. The observed events are what the occurrence of the events in the population itself. And then the expected events are events in the referent population that are estimated either in the Bernoulli, it's the fixed ratio probability, and in the Poisson, it's the background rate in the referent population adjusting for the propensity score. So now that we've done all of that, we now turn it over, we hand over this analytic data set to the TreeScan software. And when we do that, we have to decide how we want to estimate our log likelihood ratios. So we specified that for the match design, we're going to use the Bernoulli model to estimate our log likelihood ratios. For the stratified design, we're going to use the Poisson model to estimate our log likelihood ratios. And we set our alert threshold to p less than equal to 0.05. All right, now I'm going to just show you the results. So this is what we get from TreeScan after we fed the analytic data set. So starting with some basic results. So our cohort included 1,791 mother-infant pairs that were exposed to fluoroquinolones during their first trimester of pregnancy, and 8,739 mother-infant pairs that were exposed to cephalosporins in their first trimester pregnancies. When we did one-to-one matching using the general model, we retained 1,791 matched pairs in each arm of the study. So this is the huge drop here. So we went from 8,739 cephalosporin exposed mother-infant pairs to 1,791. So the good thing is that every exposed patient or every mother-infant pair exposed to fluoroquinolone had a close enough match in the cephalosporin arm, but we've lost so many patients in the cephalosporin arm. When we use the propensity score model that includes general factors and indications, we retain about the same number of patients. It's 1790 in each arm. When we do it with the high-dimensional propensity score, because the high-dimensional propensity score takes into account so many different factors, they need to be very, very similar for them to be in a matched pair. So we retain fewer matches in the high-dimensional propensity score analysis. So we have 1,732 mother-infant pairs in each arm in the HDPS analysis. When we increase our fixed ratio matching, as expected, we bring back more cephalosporin users. So in the 1 to 2, we have 3,574 mother-infant pairs exposed to cephalosporin, and in the 1 to 3, we have 5,052 now. But we've also lost some fluoroquinolone exposures because we haven't found as many cephalosporin matches for them. The main result here is that there was one statistical alert, and that alert only appeared in the 1-to-1 matched analysis where the propensity score was specified using the general model alone. In none of the other analyses, the ones with better confounding control, like adding on the general and adding on the indications, the high dimensional propensity score, or in analyses with more power, which is more than one referent patient for each matched patient, we don't see any significant alerts. The one statistical alert that we did observe was for the Q31 group. The Q31 group was congenital malformations of larynx. So we'll talk about this alert in coming slides, but that's our main results from the Bernoulli model. In the Poisson model, where we did stratification, we remember that we added on a 180-day post-delivery enrollment requirement in this study. So there was an added selection criteria now, which is why we started off with a cohort that was about 80, that retained about 80% patients in each arm. So we have about 1,509 fluoroquinolone exposed mother-infant pairs and 7,165 cephalosporin exposed mother-infant pairs. But we pretty much retain that sample size in each of our stratified analyses. So with the general model, we have 1,508 and 7,160. There's similar numbers when we go down to models which also add indications and models that use high dimensional propensity score. So if you are, the attrition that we see in the stratification here is if folks are in a strata with no treatment heterogeneity. So if there is a strata where there are only fluoroquinolone exposed or only cephalosporin exposed, there's no variation of treatment in there. So that's quote unquote non-informative. And so we drop those patients from the analysis. So this very small attrition that you see with each analysis has to do with that. And in this sort of setup, our main result was fairly consistent. So across all three analyses, TreeScan alerted us to a significant unexpected occurrence of Q513 group in all three analyses. The p-value was 0.05 in the model that only included general factors, and it was less than 0.05 in the general plus indications in the high dimensional propensity score model. Our alert threshold was p less than equal to 0.05, so all three became statistical alerts at the end of this process. So those were our main results from this case study. So what did we do with this information? We have 2 statistical alerts. And so we went through a triage process where we reviewed, patient level data. There were clinical experts on the study team that reviewed patient level data for each of the cases in the Q31 group as well as the Q513 group alerted in both the analyses. And I'll show you the process of triage in the coming slides. So starting with the alert that was observed in the matched analysis, which was the Q31 group. So there were total, and this was only observed in the one-to-one matched analysis. It wasn't observed in the one-to-one matched analysis where the propensity score model only included general pre-existing conditions. So general pre-existing conditions that increase the risk for maternal morbidity or mortality. So within this Q31 group, we saw a total number of cases of 34. We did the one-to-one matched. So according to the Bernoulli model, the expected number of cases should be half of the total number of cases that we see. So the expected number of cases are 17. But 27 of the 34 observed cases occurred in the fluoroquinolone arm. So that's why we have a departure from expectation, and that's what triggered the statistical alert. And so when clinical review was done for this, some of the things that we found was that the majority of the cases, I think 23 of the 34 cases, only had one diagnosis code during the outcome window. A single diagnosis code it may be considered a rule out condition. It need not necessarily be a confirmed diagnosis. If there's a suspicion that triggers an evaluation clinically, that might result in a single diagnosis code. So typically for things like this, for a diagnosis of malformations, we may want to look for evidence of multiple codes or any sort of intervention that's proof of that being a malformation. And in this case, I think there was only one case that required surgery in that period. And the other factor to consider was that none of the other analyses within the matched design, when we controlled for confounding in a more rigorous fashion by adding in the indications, by adding in unmeasured confounders via proxies, adjustment, we didn't see this alert in any of those other models. So the determination made by the team was that this alert did not require additional follow-up. It could be explained by poor control for confounding. Now let's look at the next alert, the Q513 group. So Q51.3 actually is the diagnostic code indicating the presence of a bicornuate uterus. So this is indeed a rare congenital malformation, but this occurs in the mother. And it's generally not detected until pregnancy. It may be showing up around the time of pregnancy and delivery, especially which is the window in which this was detected, if there are complications in the delivery process. And so the reason that the alert was triggered here is that we observed 6 cases in the fluoroquinolones group, and according to our Poisson distribution, adjusting for confounding, we were expecting less than one case. So it led to a large departure from expectation, which is why an alert was triggered. But upon clinical review, wherein claims profiles for these 6 patients were reviewed carefully, all 6 could be attributed to the mother's record. So the code was present exclusively in the mother's record. And we know that this is a condition that occurs in the mother, which is typically coded for during the time of delivery. So all to say, the clinical team decided that this alert does not require additional follow-up. So wrapping up here, we essentially saw different results by method. We saw that the Poisson analysis triggered alerts for bicornuate uterus. The Bernoulli model, and only in the instance of the one-to-one matching with the general propensity score, triggered an alert for congenital malformations of the larynx. We can explain this. We know from prior simulation work that the Poisson model has greater power than the Bernoulli model. And so what we saw with Poisson may not be observed, may not be picked up when using the Bernoulli. And also within the Bernoulli model, the alert was only observed when there was a when we know that there was a misspecified propensity score model and not as tight of a confounding control. And so we didn't see any alerts when we added on when we improved confounding control, essentially. So to summarize the study results, because the two alerts were deemed not worthy of targeted follow-up, we did not observe any evidence that fluoroquinolone use in first trimester increased the risk of adverse infant outcomes when compared to cephalosporin users. We didn't, Ashley noted in her presentation that we should have about at least 4,000 exposed pregnancies to detect some of these smaller increases in risk. We did not have that. We only had 1791 exposed mother-infant pairs, so we may be underpowered here to see any smaller increases in risk. The other piece is that we were restricted to that ICD-10 era, and we were using a single database. So those were some factors there, but in general, using longitudinal databases like these are our best shot at getting the greatest sample size of exposed pregnancies we can, at least compared to registries. The strengths with registries, I'm not saying we should be using this. I'm just saying that in this instance, we were underpowered to see smaller increases in risk. The good thing was that when we used propensity score stratification, which typically we tend to think of as having slightly less restrictive confounding control, less tight confounding control than matching, we thought we may see some spurious alerts, but we did not. So in this active comparator setting, where we took care of confounding by indication, etc., it's probably worth the increase in power to use the propensity score to stratify rather than to match, and therefore get that power advantage by using the Poisson model than the Bernoulli model. So in conclusion, I have my 2-minute warning. In conclusion, the TreeScan analysis, the TreeScan system that we built here can be used for surveillance of potential adverse infant events following maternal medication exposure. If you have fewer than 4,000 exposed pregnancies, you may be underpowered to detect small increases in rare outcomes. But in general, the notable advantages here are we are able to leverage large sample sizes because this is national administrative data. We're able to leverage existing methods that Ashley spoke about to identify pregnancies in mother-infant pairs. And then we're able to scan for all sorts of malformations, either individually or in clinically relevant groupings. So that concludes my presentation. I'm sorry I took up all the time possible to cover this information. Like I said, the citation is listed on the first slide if you would like to refer back to the paper, and I'll turn it back to Judy for questions now. Thank you for your attention.
Thank you, Dr. Adamadiam. So we've had a number of questions that have come up. Most of them are related particularly to how the tree scan design particularly works. There are some questions about the particular ways that the Bernoulli and the Poisson model might be used. Each of those carries with it particular requirements of what must be true in order for the composite null hypotheses to be valid under those circumstances. And so in general, most of the questions that we're seeing are very particular to the use of these methods. One of the things that I think the speakers had noted, but I guess I'll just reiterate here, is our focus today was on infant outcomes. And as a consequence of the focus on infant outcomes, we are focused particularly on when we can identify infants and the sample sizes and populations we have where there are linked infants. And so those are essentially, there are many questions that came into the chat about, and the Q&A, about non-live births and miscarriages, et cetera. And there are other studies that can be done for pregnancy outcomes, so the terminal point of pregnancy, whether that be live birth or non-live birth, maternal outcomes that occur during pregnancy, but our particular focus today was on infant outcomes. So it necessitates a focus, of course, on live birth delivery, and then also a linked infant in order to be able to connect that maternal exposure to the baby's trajectory. And so with that, I'm not seeing any other questions pop up in the chat, so we'll give it another couple of minutes to see if anything else comes up. And in the meantime, we're going to go ahead while we're looking for questions and conclude with our poll. So first we'll have acknowledgements, actually, sorry. Yeah, let's go to the acknowledgement slide. So there are many people that put in a lot of work to bring you the program for today. There are folks that worked on the training team, both at the Sentinel Operations Center, but also at the U.S. Food and Drug Administration. And there's work that was done in pilot projects that preceded this training that was the focus of our case study. So we want to say a thank you to all of those folks who made this training possible today. And so the next slide, please, is our post-training poll. So we'd like to understand what you guys got out of today, if we could do any better, if there's other feedback you have. A reminder that all of these questions have anonymous responses, so we won't be able to know who anybody is, but we would really we'd appreciate your robust participation in this poll. It helps us to understand much more about how to cater these trainings to you in the future, what things we can improve on, what we can do better. These are annual trainings, so we take these into account before we plan for the next annual training. It's really helpful to us. And so we'd really appreciate your time filling out this poll. We're going to give a few minutes for this to be open. Okay, so I think that we are ready to close the poll. Thank you all to those who sent us feedback. We really appreciate the time that you spent answering these questions. We will look at your responses and hope to tailor trainings in the future to meet your needs. So we really appreciate the time that you spend with the poll. We have a few closing remarks that we just want to send you as our take home for today. We hope you've enjoyed the 4-session summary. We have some key takeaways. First, that the FDA is committed to enhancing and modernizing their drug safety system by continually bringing in the best data and the best methods to do so. The Sentinel system is but one component of FDA's overall drug safety program, and it is quite well suited to monitor medication use in pregnancy. Enhancements in Sentinel have led to the ability to perform signal identification analyses or to actively detect safety signals in large electronic databases. And I think that that's really the key comparative advantage that you see here with the Sentinel system. And some of the data that Dr. Martinez showed you earlier in our session, we start out with a very large population of pregnant persons that then, if we require different enrollment and other things like that, tends to narrow, but we still end up with a multi-million person population of pregnant persons and their infants in order to do our analyses. And so that very large size is a key relative strength for the FDA in using the Sentinel system to monitor medication use in pregnancy as a part of its drug safety program. And as was explained at the very beginning of our session by Dr. Ball, future exploration and maturation of these capabilities is a key part of the FDA's role in the Prescription Drug User Fee Act 7 commitments. And so with that, I'll transition to this next slide and say the next piece of the pregnancy safety studies, pregnancy safety components that are part of the PDUFA commitments is a public workshop. And so this pregnancy safety public workshop is going to be hosted by Duke Margolis. It is going to be held in September of 2023. It's been posted in the Federal Register, but registration is not yet available, but keep an eye on it and make sure that you register. The idea here is to have an open discussion about ideal post-market study designs, and including the experience that others have had and that we have had here at Sentinel System using other real-world data sources. You see, as we talked about, some of the data that we're already collecting about the number of pregnant persons that are exposed to various medications, and how many of those exposed persons can then be tracked to their infants through a linkage in order to identify infant outcomes. And so we continue to work towards preparation for this pregnancy safety public workshop, and I encourage you to register when it is available for registration. This concludes sort of day one of our 2-part Sentinel system training. This is the public training component. Innovation Day, which celebrates all the work that's being done within the Innovation Center that I've talked about a few times in some of the question and answer period today, particularly looks at how to leverage unstructured data that's available in electronic health records, amongst other sorts of new initiatives there. They're going to be talking about some of the work that they have been doing, and that is tomorrow at 1 p.m. There is a link for registration. It is the identical link to the registration for this workshop, but I encourage you to attend part 2 tomorrow at 1 p.m. We hope to see you then. Until then, thank you so much for your time and your great questions today. We had a great Q&A session. We really appreciate all of your input and feedback. We look forward to seeing you tomorrow. Thank you so much.